Hi and welcome. My name is Josh Lumbley, and we're going to have a three-part lecture series on ethics, practice management, and medical legal issues. This is going to be part one that we're going to go into. Now, a couple points that I want to make before we get started. This is a lot of information that you may not be incredibly familiar with. The concept of practice management, some medical legal issues, and frankly even ethics is not something that's heavily emphasized in residency, but it is something A, that's important for you as an anesthesiologist to know, and B, it is something that's very high yield on the exam. So what we are hitting is the high points. All of this is information that will help you in your future as an anesthesiologist, but also on the exam itself. Pretty dense material. We may not go into excruciating detail, but we're going to hit the high points, and this is all information that'll really benefit you well on the written exam. So without further ado, let's go ahead and get started. So this first lecture, we're going to cover general terminology, types of risk management and focus, accreditation and regulatory aspects, and then finally the systems perspective. So for the next 20 slides, we're going to do a deep dive into general terminology and just lay some basic definitions. Who of the following legally competent patients is not capable of giving informed consent? A, an emancipated minor. B, a parturient in labor. C, an adult who just received sedation for an attempted reduction of a dislocated shoulder. Or D, an adult who is refusing recommended medical treatment. And the answer here is C, an adult who just received sedation for an attempted reduction of a dislocated shoulder. So emancipated minors, non-sedated, neurologically intact adults, those individuals are all capable of giving informed consent. A patient, however, who has just received sedation is not an appropriate selection for informed consent. Obviously, most of us know this with regard to preoperative evaluations and needing to do a regional block in a patient that, say, may not have signed the surgical consent. Obviously, we have to hold off on administering fentanyl and Versed or some sort of anxiolytic to relax the patient before our regional block until that patient who's neurologically intact has signed his consent and given written and verbal consent for the surgery. So informed consent implies a respect for autonomy of the patient. Verification of it is critical for medical legal cases, and it involves 7 distinct components. You don't necessarily need to memorize these 7 components, but need to kind of, in general, understand their importance. So the patient has to demonstrate decision-making capacity. It has to be a voluntary decision, can't be coerced. The patient has to disclose any risks. The proceduralist has to disclose risks. It offers our best recommendation for the procedure. The patient needs to demonstrate understanding of what he or she is about to go through. The patient needs to be able to make his or her own decision, and the patient has to imply autonomous authorization. So decision-making capacity, so that is a critical one. Is the patient able to make a particular decision at that specific time? So they've got to be able to understand the proposed treatment versus the alternatives. Do we want to continue with antibiotics, or do we need to go ahead and do the amputation through our infected lower extremity? They need to be able to express a preference on reasoning that includes an understanding of the consequences, the benefits, and the patient making the best choice for him or her. So do I want to proceed with, if say I've had an amputation, do I want to proceed with going in a wheelchair, or do I want to try a prosthetic? Decision-making capacity implies having the sufficient ability or possessing the requisite natural or legal qualification to engage in a given endeavor. So a patient has to be competent, and why is that? The patient needs to be competent in when they are making their decision. Where does that impact us? when we give a patient sedation. So a competent patient initially that receives sedation will have impaired decision-making capacity and therefore not be able to provide appropriate informed consent. Legal competence does not imply decision-making capacity. So what is sedation, and where is sedation sufficient that decision-making capacity is impaired and that patient is no longer legally competent? So an anesthesiologist has a general responsibility to evaluate that patient's ability to make an informed decision before beginning any sedation. You can't do this mid-procedure. You can't flip through the chart after having given 5 of Versed and say, oh my gosh, we don't have consent. Let's stop this patient. They're awake, and let's go ahead and get their consent. Now, does this impact patients that are in labor, that are in a lot of pain and are saying, just give me the epidural, just do it now, just do it now? Studies have found that a patient who is in labor, they are neurologically intact and they are legally competent. So the pain of labor does not interfere with the ability to comprehend any of the information that you as an anesthesiologist are just disclosing to the patient, and therefore they can provide informed consent. So informed consent has to be voluntary, so the patient has to be willing to undergo a procedure without manipulation or coercion by me as an anesthesiologist or the surgeon. It can't be, the information cannot be manipulated. So information can't be distorted to imply a overestimation of risk or frankly an underestimation of risk that might influence the patient's decision to proceed or not to proceed. Disclosure. This part is sometimes a little bit challenging. How much information do you disclose? Do you go into explicit detail when you are consenting a patient for anesthesia who's having back surgery? Do you go through in exquisite detail the risk of postoperative vision loss? So what would a reasonable person want to hear? That's the standard, and that's the most common application that we do. So what would a reasonable person need to hear and view as important for making an informed decision? Autonomous authorization. So the last component of informed consent. So the patient has to inform the physician of the decision and intentionally authorize that physician and the anesthesiologist to perform the anesthetic procedure, and intentionally authorize that surgeon to proceed with surgery. So this allows a legally competent patient to be able to refuse recommended medical treatment. So where is this important? Obviously, you see in the lower right-hand corner of the chart there, refusing no blood, advanced decision to refuse specified medical treatment. So this is pretty common in our Jehovah's Witness patients, that despite having large surgeries where you might say you need blood, the patient who is legally competent can refuse our intervention. So we're going to shift a little bit now to define what are emancipated minors. So emancipated minors are patients that are under 18 years of age that have been given the right to make their own healthcare decisions. So these may be married patients, they may be pregnant patients, they may be parents, but they need to also demonstrate economic independence. So long question stem. Well, let's dive right in. So you've got a 79-year-old man with acute myelogenous leukemia. He's intubated and ventilated in the ICU. He's got multiple organ failure, his leukemia has not responded to treatment, and he's totally comatose. Based on his previously stated wishes, his family wants to withdraw support and provide, quote, comfort care only. The patient's trachea is extubated, and he breathes at a rate of 35 breaths per minute and appears to be uncomfortable and gasping for air. You start an infusion of fentanyl and Ativan as required, and both drugs are titrated to respiratory rate of 10 to 12 breaths per minute, and the patient appears comfortable. 2 hours later, the patient dies. One of the patient's family members then asks, were these drugs given to end the patient's life? In these circumstances, the most appropriate response would be that the specific act of sedative and analgesic administration was based on which of the following principles? A, non-abandonment, B, double effect, C, paternalism, D, autonomy, or E, informed consent. And the answer here is double effect. So non-abandonment is not the correct answer in this situation as you've remained present, or the provider has remained present throughout the procedure. They've not abandoned the patient. Paternalism, autonomy, informed consent, they're not germane to this question. They're not the appropriate answer choices. In this case, double effect. So what is double effect? It's an action that gives harmful effects. So decreases the respiratory rate and may increase CO2 and thus speed up the progression to death. But those harmful effects are virtually inseparable from the good effects. Patient is now comfortable. Patient isn't gasping for air. Patient appears to be more calm. The good effects. Double effect is the correct answer in this scenario. So principalism is an approach that we use for medical ethics, and they're proposed by Beauchamp and Childress. So number one, you've got autonomy. So the patient has a right to self-determination. This is versus paternalism, where you're making a decision for someone else. Beneficence. So it's a good faith act on the physician's part to preserve life, relieve suffering, restore health, and restore or maintain function. So in that previous question, while life may not have been preserved, we are relieving suffering. Non-maleficence, do no harm. And then finally, justice. The moral obligation to act on the basis of fair adjudication between various competing claims. Giving a drug that may speed or hasten death versus not giving a drug and the patient looking very uncomfortable, respiratory rate is increasing and the patient is gasping for air. So two different claims. So principalism is, obviously, we're continuing this, the approach to medical ethics. So Beauchamp and Childress proposed these. So let's do a deep dive into autonomy. So it's the right to self-determination versus paternalism. So paternalism or parentalism, so that is a way to bypass autonomous decision-making by the patient. So it is, in fact, justified in certain cases. So if there exists a risk of significant preventable harm to the patient and the harm will be prevented by the paternalistic action. So those projected benefits of intervening with this activity outweigh the risks of the patient of not doing this. If we're going to do this, then we need to do it in such a way that we use the minimal restriction on the patient's autonomy as possible. So beneficence and non-maleficence. So you want to benefit the patient and you don't want to hurt the patient. So that goes back to our earlier statement on double effect. So double effect is an action where you've got some harmful effects, but they're practically inseparable from the good effects. And that is justifiable if the act itself that you're doing is good and morally neutral. So the act of giving this patient fentanyl and Ativan was a good act to relieve suffering. The person performing the act must desire only the good effect. So administering these drugs, we're not trying to hasten death, we're trying to make the patient comfortable. And the good effect must not be produced by means of the adverse effect. And the beneficial effect, as per that patient's wishes before they entered the hospital, must outweigh the adverse effect, in this case of hastening death. So now we go to justice. So we talked about autonomy, we talked about beneficence, non-maleficence, the double effect, and now justice. So justice is linked to fairness, entitlement, and equality. So we are going to, if at all possible, try to distribute resources, scarce resources in a fair manner. That's distributive justice. We've got to respect people's rights, so that's rights-based justice. And then we've got to respect morally acceptable laws, so that's legal justice. So what is abandonment? So it's the practice of leaving a patient for whom the physician has provided health care in the past without providing immediate or future medical care. So that's leaving a patient that you're caring for and abandoning them. So once a patient and the physician mutually agree to enter into a therapeutic relationship, whether it be in the operating room or in a patient-physician office, the patient has a duty to provide ongoing care. Types of risk management and focus. So traditional risk management, it's a dynamic process, continuous, ongoing process that goes in a circle where you're looking to try to identify risks, constantly trying to assess those risks, and if possible, predict them before they happen or prevent them. If there is a risk, you're trying to minimize that risk and make the effect of any adverse outcome as small as possible and control it. So ideally, you want to be in a situation where either A, it's impossible to make a mistake, or a condition whereby making a mistake is so obvious and so easy to pick up and correct that it's impossible to propagate that risk forward. So we have clinical risk management. So it's a proactive risk management that reduces the risk of injury to patients, visitors, employees, and preserves the financial resources of the organization. It integrates with quality improvement, quality initiatives where you're trying to pick up risks and minimize their ill effects, analyze specific behaviors and practices that subsequently lead to loss and litigation. And then, of course, we have financial risk management, which is it may benefit us to avoid clinical risk because we can protect our financial assets, but financial risk management strictly comes from the financial side of things. You're strictly trying to protect financial assets. So previously, when we had a pre-just culture, proactive culture, that our culture was defined by reactivity, blame. You're focusing on the individual, not focusing on the system, trying to hide, conceal, deflect the true owner of the risk. You're trying to prevent financial loss as opposed to looking in the future, and the patient is kind of a passive recipient of it. They're not really involved in that process. And where we are evolving today is to a much more proactive evaluation of risk management, a just culture where we're all the same. Anyone can say stop, can stop the line if at all possible. It's systems focused. We don't focus on the individual, we focus on the entire system and what allowed this condition, this ill effect to occur. We always want people to disclose and not hide errors. We focus on improving outcomes and preventing these sorts of scenarios from occurring in the future. And the patient is an active participant. The patient needs to be involved in this process. So the behavioral concepts of risk management are human error, negligence, and intentional rule violations. So human error is they should have done something else other than what they did. They grabbed, thought they were filling up an ampule of lidocaine, and in fact they were filling an ampule of epinephrine. Negligence, so failure to exercise expected care. They should have known that this patient, having just eaten 30 minutes before going to the operating room, was at a high aspiration risk and therefore should have done a rapid sequence intubation or potentially canceled the case. Or intentional rule violations, conscious disregard of substantial and unjustifiable risk. So who are our accrediting bodies and regulatory bodies? So if all of us have looked at CMS.gov, and right now we're focused on conditions of participation with CMS. Anytime you join a practice, you're going to try to characterize and manage all of the CMS verified conditions of participation. So some of those CMS conditions of participation are performance improvement activities. This can involve using some digital device that tracks medical errors or adverse events. You look at those causes longitudinally, and you implement preventive actions and mechanisms that give feedback to the individual and feedback to the system, and ongoing education to prevent the reoccurrence of those injuries. Ongoing program for patient safety, including the reduction of medical errors. It's defined, it's implemented, and it's maintained. And there are clear expectations for safety that are established. The Joint Commission, on the other hand, is different, of course, than CMS. That entity manages safety risk. It's integrated patient safety program that you implement at your facility, and then it is evaluated subsequently with later visits. Defined response to unanticipated events, and you're conducting proactive risk assessments during these evaluations and participating in risk reduction activities. Okay, so for the next 5 slides, now we're going to evaluate it from the systems perspective. Reactive versus a proactive culture. So with a reactive culture, there is data analysis that we look at longitudinally, and we only focus on the negative outliers. It requires a retrospective peer review. So something has occurred, and now we are looking at it retroactively. Typically, that is a sentinel event or a bad outcome. We use a quality improvement organization or peer review organization receives a complaint, and we evaluate that provider. Oftentimes, there is a claim or a lawsuit involved in this event. And then we typically do a root cause analysis. A multidisciplinary team convenes and looks at the various conditions that enabled this ill event from occurring. So reactive, you are reacting to an event that has happened in the past. Ideally, we're going to be using a proactive management. So we use evidence-based tools to look at current state conditions and proactively predict issues that may occur in the future. Oftentimes you're using a FMEA analysis, so failure mode effects analysis, to predict where challenges may occur in the future or where events may occur in the future. You're looking at data analysis and not just looking at the negative outliers, but you're looking at data analysis to be predictive and follow trends and patterns and be able to say, does this event occur on some sort of cadence? Do we have an exquisitely high likelihood of this event occurring again based on looking at data? Are there near misses, etc.? So failure mode effect analysis, that is trying to say my default answer is no, it is not safe. Okay, so with a failure mode effect analysis, you want to be proof. There needs to be proof that what it is you're about to do is in fact safe. So systematic analysis of a process to identify all of the possible ways that it might fail. What are those effects of failure? And then the possible causes of those failures. So it was introduced in the 1960s by the aerospace industry and is highly applicable, of course, to healthcare. It's recommended for use in healthcare by the Institute of Safe Medication Practices, and it's required by the Joint Commission. So we use an FMEA to predict failures in systems. We're trying to eliminate or minimize that possibility of intolerable errors, errors that result in an adverse effect on the patient. Try to trap the error before it reaches the patient. Again, as I said, you want to create a scenario where it's either A, impossible to create an error, or B, the error is so obvious when it occurs that you can fix it before it ever even gets to the patient. And you minimize the consequence of the error when the potential cannot be eliminated. So again, we're not trying to react, we're not forcing blame on the individual. We're looking at it from a system and saying, what type of system are we in that enabled this mistake to occur? And that is it for our first of 3 lectures on ethics, practice management, and medical legal issues. Thank you.